that's the current theory that people operate under. But actually, there's not a new, it's been around for the last 100 years, but a theory called the mitochondrial metabolic theory of cancer, which is now gaining a lot more, what shall we say, substance, because there's a lot of research being done.
Hi guys, and welcome back to another episode of the Medic podcast. Now today I've got returning guest Dr. Nelum Dharmapriya today. So thank you, Nelum, for joining us today.
Thanks, Suresh. Thank you for having me on.
Oh, you're very welcome. Anytime, you're always welcome. Now, Dr. Nelum has a really important story that she wants to share with us this evening. It's very, very close to her heart, and it's going to be I think, a really interesting discussion this evening. So, Dr. Nelum, over to you to give us your story.
Thank you, Suresh. Yes, so the last 2 months have been really very difficult because my brother was diagnosed at the beginning of December with stage 4 lung cancer. With metastases or spread to his brain, multiple metastases, and I think they counted in number 15 metastases to his brain. And this was, and then when they looked for the primary, it was in his lungs. Now, he has never smoked. He was a very active man, mountain biking, skiing. He lives in the US, hiking, swimming. That's what he loved to do. And that's what he did whenever there was good weather over there. And this came as a shock. There was no history of any of this in our family. And it only presented, the symptoms started 2 weeks prior to his diagnosis. He started getting dizzy, and those were the only symptoms, and dizzy, and also kind of like a little bit of blurred vision. And coming from a kind of a Sri Lankan background, well, the family were convinced that that he was having a stroke. And when the scans, the MRI scans, revealed that he had these metastases, that was a massive shock. So anyway, and because of so many of these lesions in the brain, there was a lot of intracranial pressure. So the skull is a fixed structure. So when there's a lot of what we call space occupying lesions in there, that just increases the pressure within the skull. So that then is a really concerning problem. And he also had what we call midline shift. So the pressure had increased so much that it had shifted some of his brain to one side. And this was a real concern, and because this could be life-threatening. So he was started on high-dose steroid. There was one particular lesion that was very, very large. So the surgeons, the neurosurgeons were planning to remove this lesion, but until then they started him on high-dose steroids that suppress and keep the inflammation under control. And he had the surgery. He had a craniotomy, and he did really well. There was no issue with that. And then when they did the genetic profiling of his lung cancer, they found that he was one of, I think, 1% of people who get lung cancer who have this particular mutation that is really amenable to a type of immunotherapy called tyrosine kinase inhibitors. And that really changed his prognosis. And the oncologists were very happy and being able to give him a much better prognosis, because initially when he was diagnosed, he was, stage 4 lung cancer with multiple metastases to the brain. We're not talking long. But with this mutation, he was given, he was told that he could easily live for 5 to 10 years, possibly longer. He would have to take the medication lifelong. And so it was such a big, the whole family, it was amazing.
Mm.
So that was wonderful, but this was just before Christmas, and therefore, and because this is all in the US, everything has to be approved through the insurance companies. So these medications, it took time to come through, so he'd had his craniotomy. He was on his he was on the high dose steroid for his to keep the inflammation down, but there was really nothing to actually stop the growth of his cancer. And 2 weeks after his craniotomy, the steroids were being tapered down because there was less pressure because the largest lesion was removed. And then he started getting these double vision and all those symptoms again. And when repeat MRI scans showed that his lesions not only had they increased in size, they had multiplied as well. And that was, I mean, it was just, yeah, it was such a shock because in such a short period of time. And so he was recommenced on this high dose steroid. And at that point, so this was literally just before Christmas. And at that point, I decided that I needed to go and see him. My sister, so my sister and I, obviously I'm a GP. My sister is a radiologist. So she was there in the initial bit, and then I went over. And really, we had talked to him, my brother, about starting on a ketogenic diet. Now, my brother is an engineer. He's not really very au fait with any medical stuff, but he was really he really wanted to do whatever he could to improve his health and his possibility of survival and improve his likelihood of survival. So he was really keen to start on a ketogenic diet, and we'll talk about that, Suresh, why that was. And he was doing really well with that. And also I wanted to introduce him to fasting. So when I went, I left on Boxing Day, and that was the idea. And so when I got there, I realized that he slept very little. He was sleeping 2 hours. Um, and when I initially got there, he was a bit tired, as you would expect. He was, he needed to sleep in the afternoons to catch up. But he said that the keto diet was really giving him a lot of energy. And as the days went on, I realized that he had amazing energy. I mean, he was from 2 o'clock in the morning till midnight, he was on the go. He was on the go. And what he was doing, because he was given this uh, improved prognosis, he wanted to do everything that he wanted to do, and he had this list of stuff. Particularly, he loved his house. He and his wife built his house 10 years ago, and there were always things that he hadn't quite managed to finish. So that was the big thing. He was going to uh, finish, and like to the highest possible standard, his house. So there were designers coming in, there was furniture being delivered, there was expensive, like there was so much going on in the house when I got there. And then holidays, he's a real traveler, and his 25th anniversary was coming up, so he was planning all these holidays. So I realized that a few days when after I got there, that yes, he was on the keto diet and he was reasonably on that, but he was really distracted. There was so much going on. There were bicycles and multiple appliances, and there was packages coming morning, noon, and night, and the whole household was in an uproar. And um, and then as this went on, I realized that there was not something didn't seem right. My brother was always a quiet man. He didn't talk much. He kept to himself, and he wasn't he wasn't like me. I talk a lot, but that wasn't him. But I realized that my mom mentioned something. She said, he talks a lot. Then I realized that from the moment we got up in the morning till the moment we went to bed, you could hear his voice kind of talking, droning on the whole day, different cadences, but and 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 then he was getting a bit irritable. He was getting he would go, so there was a lot of money being spent, and every morning when we got up, spending money. And if you asked him, like, what are you doing, like, why are you spending all this money, he would get really upset. And then and then also get a little bit teary and get very emotional, and that again wasn't my brother. And then I realized that this was an acute manic episode. That's what we were witnessing.
Yeah.
um, and it took a few days for it to, because you don't kind of expect that, and there was never a history of that in the family, or he's never experienced this. And I mean, it could have been one of many things that triggered that. He was, very poor sleep. He was on very high doses of dexamethasone for his metastases in the brain. He also had multiple metastases in his brain, that particularly in the frontal lobe, which could also be triggering this.
Mm.
Um, but really, the only thing that we could do was, in my mind, was to maybe start reducing the dose of steroid. But I mean, I couldn't do that. I'm not his treating clinician. So then trying to get him seen by somebody, trying to get a mental health perspective or a review, or trying to get some kind of management of his mental health, because he was also then by then now getting a bit aggressive as well. So he'd go from being very happy and laughing, and these, as you know, Suresh, these grandiose ideas of, I'm going to beat this cancer, I'm going to write a book, I'm going to make $1 million, all of this. And then the next moment, very kind of angry and verbally aggressive. And it was very stressful for the family. My elderly
Mm.
parents were also in the house, because they'd come to help the family. His wife and his two kids were there, and including myself. So it was a very kind of stressful period of time. And it was really hard to get any sort of treatment for this. And system difficulties, really. Trying to, in the US, well, in the state he lives in anyway, there was no way that we could email. There is no email for any specialists or any GPs. You had to call them, or you had to physically go and see them. And I mean, it was, you and I know how difficult it is to call a doctor in the middle of a busy day. So what I had to do was, and obviously I tried to speak to my brother about these symptoms, but he wouldn't have anything. He felt
Mm.
amazing. This was the best he'd felt. He felt he had this amazing brain power. Why would he, like, there was nothing wrong with him.
Yeah.
So then I had to be very, very careful about how I did this. So I wrote multiple letters, and one morning I just got an Uber, went to the hospital, and went and went to the specialist, his radiation oncologist and his oncologist. And you can't really speak to them, but I gave the letters to the admin people and said, this is so important. This needs to be addressed. And eventually, his oncologist got in touch with me. And then finally his yeah, well, no, so then there was this whole discussion of, well, what do you want us to do? And so I said, he needs to be in hospital, because he's a risk to himself. He's a risk, I felt, to the family at that point. And also what I was suggesting was that we reduce the dose of the steroid under their guidance. But then there's also, Suresh, the concern about the fact that the steroid was the only thing that was holding his brain, the pressure. So by
Mm.
reducing steroid, his metastases just went crazy within 2 weeks, what would happen? So I really felt that he needed to be in hospital. And there was so it was an interesting conversation because so as soon as I said, I think there's a risk issue here, then the oncologist said, well, then you need to call an ambulance and get him into hospital. And I realized that sometimes I would say that to my patients here in Australia. And I realized it is not, you cannot just get somebody into hospital if they are in this scenario. It's very, very difficult. So this went on for a few days. We didn't get him admitted at that point, but then he developed acute urinary retention on top of that, which is the inability, as you know, to pass urine. And his bladder was actually up to his umbilicus. And that's a surgical emergency, urological emergency. He had to be admitted to hospital. And so that at that point, I decided, well, I really tried to kind of speak to the emergency doctors now about his mental health state. Again, it was quite difficult, but eventually we got him admitted and got him seen by psychiatrists. And finally his steroid doses were reduced, tapered, and he was commenced on medication to help him sleep, and also medication to reduce his agitation. And so then within a few days, well, it took about a week or so for these manic symptoms to settle down. It was very, very distressing, that whole period of time. And in the meantime, he had actually the immunotherapy that he was supposed to have started came through, and he had already started that. So this is a specific. It targets this particular lung cancer, this mutation in this particular lung cancer, and it does actually have it gives a pretty good prognosis, but it doesn't cross the blood-brain barrier. So, and there are, yes, so interestingly, there are these immunotherapies that cross the blood-brain barrier. So when we ask, well, why would we start on something that doesn't cross the blood-brain barrier when there are ones that do? But it's the standard of care in the US. The standard of care states that this is the way we do things for this cancer. And I think, from my understanding of it, is that it is governed by also the insurance companies as well, and what they pay for. So there's not a lot of opportunity, I think, for clinicians to just say, okay, well, in this case, we'll do this. I think he had to go through these various options. And so, so then at that point, I'd been in the US for 3 weeks. I had to get back to my patients and my life at home. And I was happy that he was in hospital. His manic symptoms were settled. He was starting radiotherapy for his brain as well, because one of the lesions was in his brain stem, and that lesion had grown. And lesions in the brain stem are very dangerous because it can cause it can cause seizures, it can cause herniation of the brain. So his radiation oncologist wanted him to start on radiation, whole brain radiation, which wasn't ideal, but well, that was what was offered at the time. But then he started to become breathless, and he needed oxygen. And again, that was really, he'd never had problems with any of this. And then it turned out that, well, uh, blood testing revealed that he had that, and imaging revealed that he had what they thought was a pneumonia. And they then treated him with oral IV antibiotics, but nothing worked. And he was actually getting worse after a week. And we couldn't understand what was going on with him. Then we realized that the medication that he was started on for his cancer treatment, um, uh, a small percentage of patients, less than 2%, get this interstitial inflammatory, it's an inflammatory lung condition called interstitial lung disease or pneumonitis, which if you get it, there's a 50% chance of death. And I just knew that that was what was happening. And then he just, within a few days, he just couldn't breathe. He was getting exhausted by having to try and breathe through this, and the treatment for this was high dose steroid. But because they had to treat this potential pneumonia first, I think by the time they started him on the high dose steroid, it was too late. It wasn't an oversight in any way, because they had to make sure that they were treating any infective pathology. But and what happened was that he was getting so exhausted that they then had to send him into ICU, put him on a ventilator for mechanical ventilation. And at that point, our whole family fell back, because we just, anyway. And he 3 days later he passed away, because he he um, he couldn't he couldn't breathe by himself, and there was the high dose steroid, the mechanical ventilation, it didn't make any difference. In fact, he deteriorated further, and there was no possibility that he could manage to breathe by himself. So, Suresh, 2 months following his diagnosis, well, less than 2 months, he died of interstitial lung disease, secondary to the immunotherapy that he was started on. And the previous, very distressing manic episode was also secondary to the steroids that he was started on. So, it was a very harrowing journey, but it really opened my eyes as to we are a medical family, and this was a complex case, and so I was really grateful that my sister and I had that understanding. And I feel, what happens to families that don't have that medical support to have gone through something like this? I don't know how people would do it. So that was a really humbling, sobering thought for me, really, that I was grateful that I had that knowledge. Um, yeah, so yeah. So that's my story. That's my brother's story. And I felt that I really needed to talk about it, because I think there's so much that we can learn, and there are alternative treatments. And that at the end of the day, that these treatments that are used for cancer therapy, they are also highly toxic. And I think sometimes when somebody is diagnosed with a stage 4 cancer, they're so desperate and worried and scared that they take, this is the only option that is given, and so therefore that's all they take. But I think there are other options that maybe could have been, I think that what if there was something else? I think in my brother's case, I don't think this would have helped. Anything else would have helped him in terms of survival. But I think maybe the lifestyle therapies that you and I use might have helped in terms of comfort, keep him more stress relief, keep him in a more peaceful state in those last 2 months of his life. So yeah.
I've said it off air, but I'll say it on air as well. Obviously, my condolences to you and your family, Nelum, and I really appreciate you coming on the show. I know you reached out to me and you wanted to share this story for my listeners, for the viewers, because you want to get the word out that maybe there's other ways of approaching things. I mean, we'll go back and clarify, some of those issues, but yeah, I mean, that's a very, very powerful story. I'm almost in tears over here, listening to it. It's a very, very sad story, but close to my heart. My father died from interstitial lung disease as well,
Right. Yeah.
which not a lot of people know. I don't keep it a secret. It just it doesn't come out in conversation very
No,
often.
that's right. Yes.
And it's a truly horrible condition. People think things like dementia are bad, and they are, of course. They're terrible. They're disastrous. Interstitial lung disease, I feel like, it's in a whole nother level. I think the best way you can describe it, or I could describe it to someone, is what it's always been described to me in my experience with my father was, his was slow, but yeah, basically just drowning without
Yeah,
water.
exactly.
Um, I think is the best way to put it. You just feel like your lungs are just slowly filling up, and you just can't breathe.
Yeah.
And my father was a steady decline, but yeah, by the end of it, I mean, I'm just grateful every time when I think about him that he went into hospital and he picked up a cold and passed away,
Passed away.
because
Yeah.
it just put him out of his misery, and he just had no existence. They never found out what the cause with him was. I've got my theories. There was no, like medications or anything involved with him. It was
No.
just
Yeah.
deemed idiopathic. We don't know what the cause is. I suspect it was down to things like oxalates and so on. I mean, he wasn't a vegetarian, but coming from an Indian background, had a pretty
Yeah.
heavy vegetarian or plant-rich
Yes.
diet. Of course, I can't prove that, but I suspect oxalates. They are suspected to be heavily involved with lung fibrosis.
Right. Okay.
So I suspect that's what the issue was with him, but of course I couldn't prove that. Had I known then what I know now, maybe I could have done something. Probably not, but
Yeah, but I think just to, well, I don't know. I mean, there is no harm in trying these things, right? I mean, what do you have to lose?
no,
Uh,
I mean, I
yeah,
say really to myself, I don't think I could have made any difference, because if I think that I could have made a difference, well,
yeah.
that would drive me
Well,
crazy. So I
but
think
you can only know what you know now, right? You didn't know it
exactly,
then. Yeah,
I didn't
exactly.
know back then, but very, very powerful story. Again, my condolences. I just want to go back and touch on a few things, maybe explain to some of the listeners and viewers, maybe some of the medical
Yeah,
terms that we used there. They're probably, most of my listeners and viewers are very intelligent people. I'm sure they know most of that already. But so you were speaking a little bit about the blood-brain barrier, and that's just so people, I'm sure they know. Obviously, your brother had brain metastases, and what we're talking about there is essentially for something to treat inside the brain, it has to cross
yes,
into the brain, and the brain is kind of surrounded by this barrier, this shield.
yeah,
Because generally it's bad if like bacteria and viruses and all these kind of things can actually get into the brain. So it has this barrier around it to try and protect it. And some medications can cross that, some can't. And so that's what we're talking about there with the blood-brain barrier. You also mentioned, of course, this condition called mania, which again, you kind of explained there, but just in case people missed it, it's kind of this condition where people just get this over excessive kind of happiness, quite, I mean, opposite basically in a way to depression, which is obviously a very kind of tends to be very low mood, of course, psychomotor retardation, so just very kind of slow thoughts, slow behavior, and so on. Mania is very much the other way, this very elevated mood, abnormally elevated, persistently elevated. Often get these, what you said, grandiose ideas that they can just do
yes.
anything, be anything, often spending lots of money. Very, very
Energy.
difficult
Yeah,
to, when you're talking to them, they can't stop talking, constantly changing their mind on doing, different things. It's like ADHD on steroids, if you'll
yeah,
excuse the term.
exactly. Yes.
But can be triggered by steroids, and presumably you thought that yes, that was actually the steroids that were doing it. When they brought those down, then the
Symptoms
mania
disappeared.
improved within a week.
Yes.
So of course there were other things to contend with, but then of course by the end of it, well, he kind of needed those steroids for the lungs. So obviously just very, very challenging, kind of all
Yeah.
around. it sounds to me like you're not blaming any one particular person.
No, there's no blame, because at the end of the day, the way he presented, he needed those steroids. He needed, and there was the medication induced fibrosis as well, whatever. And I would probably think that if he was told, he wasn't told about that. That was the only thing I would say, that he wasn't actually told about any of these two complications. But even if he was, and said that less than 2% of people got this, he would have thought, well, that's not going to be me, because nobody thinks that they're going to get it. And there wasn't really any other alternative from conventional therapy. So I think he would have taken it anyway. So no, there's no blame, but it was just really looking at, yeah, how we manage cancer, how we manage these end stage, kind of cancers, which not just end stage, but just generally cancer itself. And we use these very strong treatments that are not without, well, obviously there are risks, because then they can be more toxic than the actual disease itself.
Sometimes, and of course, we're talking about cancer here, but there'll be a lot of people listening out there that they're on things like essentially chemotherapy for arthritis, and methotrexate, and all these immune modulators, immunotherapies, and so on. And yeah, they do have side effects, very, very real side effects, and there may be other ways of treating these kinds of conditions, which we're just not particularly good at. I mean, you and I, of course, know and do this kind of work, out there, low carb and anti-nutrients and keto diets and all of this stuff, which we'll get into. But I think, the majority of the physicians, I was speaking to someone the other day, I won't name them because I haven't got their permission, but they kind of just said, a lot of doctors, they just kind of don't get it.
Yeah.
It's just the way that they put it, and just it's not on their radar. But of course, it sounds like in the States where your brother was, that even if it was, they may not have been able to actually do that because it's not in their protocols. The insurance won't allow them. And
I mean, that's the impression that I got, that they couldn't really deviate from their standard of care. So anyway, yes, so at least I think we're a little bit better here. I think we still have the ability to make clinical decisions in Australia. But yeah. So
I
that's
think
right.
we are probably better here with that. But I think that's a really important point, though, because I mean, at what point are clinicians actually leading the care, and at what point are actually the financial, the backers, the bankers, the insurance companies, the hospitals, at what point are they actually driving this care? And is that then the best care if the clinician is saying, well, no, I want a different drug, as you said, the one that's actually going to treat my patient perhaps more effectively, but then the insurance says no, because you have to do this first, which I don't think that would sit great with me.
No, exactly. The other thing, Suresh, that was that during these last months of my brother's life, because he was very much involved with oncology and the hospital, his GP wasn't involved, and I found not having a GP involved was a real challenge, because there was no one to advocate for him or to oversee his care. And at the end of the day, I'm his sister. I'm not there as his clinician. I'm just there to support him. And it was very, very challenging. And I feel that, a good GP is worth their weight in gold in a situation like this.
Yeah, absolutely. I mean, they can often help to be that go-between, especially someone who knows the system. I mean, you as a doctor, yes, but as you said, you're there really as a family member. You don't want to be taking the role of a clinician.
No.
You don't have the insurance and all that
No,
stuff. You
exactly.
also don't know the system. You don't
No.
know how things work,
Yeah.
and so it shouldn't fall on you then to be trying to make those decisions and to take that position there. So. So that, I mean, that's a shame. It sounds like that the insurance and the protocols were almost hindering, perhaps the treatment that your brother maybe could have gotten.
I mean, I don't think it would have made a huge difference, Suresh, because I think the other interesting thing was the only thing that I suppose, is that my brother, he didn't have any allergies to any medication, but he was a highly atopic, highly allergic individual, to the extent that every single item of clothing that he owned had to be in these protected clothes bags, because otherwise he couldn't. He would sneeze kind of constantly. There was so
Mm.
if so when the questions are asked, usually it's, are you allergic to medication? So I wonder if there was just that, this realization that this individual is a very atopic individual, and therefore whether they needed to monitor this person a little bit more closely when it came to the inflammatory lung disease. That was the only point that I would potentially make. But that's, again, I think, a good learning point for us as well, not to just ask about allergies to medication, but generally, are you, do you have allergies? I think is a good one to ask. Yeah.
Yeah, I think it is. I mean, that's usually what I do. I mean, I'm sure I'm guilty of just saying at times, are you allergic to any medications,
Yeah.
especially if
Yeah.
people list off 1,000 things that they might have a sensitivity to. But
Yeah, that's right.
you have to do sometimes narrow it down a little
Yeah.
bit for people. But no, I think that's a very, very good point. And I mean, you kind of mentioned, I think, and forgive me if I'm mistaken in this, but I think you mentioned off air when you contacted me, Dr. Nelum, that you were finding it, I think, a little bit frustrating that the kind of the oncology team, you felt that they weren't really taking the mental health side kind of seriously, and it was like, well, we're oncologists, we don't kind of deal with that. Was
That
almost
is
the impression that I got
exactly.
from reading what you wrote to
That
me.
is exactly. I had to call, so truly, I must have been the biggest pain in their backside. I had to call so many people, so because you can't reach the consultant, you have to talk to this. There are nurses, so and that's exactly what one of the nurses said. She said, but we're an oncology team. I said, but then who is responsible for him? Like,
Yeah.
who is responsible for these? Like, how do I get my brother seen by a psychiatrist, or what should happen here? And um, and it was very difficult. So that's when actually the oncologist did eventually call me, and it was very interesting. Her question to me was, she said to me, well, you're a medical family, what would you like me to do? And I said, well, but we're not his treating team. We are just family. What
Mm.
would you do? And then she said, well, if it was me, I would want to get him admitted. I said, well, that is exactly what I'm
Yeah.
saying.
So
But
admit him, but
yeah,
they just
yeah.
they
But then
couldn't,
she
or
said,
they
well, then you need to
wouldn't,
get him
or
in. Yeah. I said, well, that's the point. Like, how can you get a person who has acute mania in just like
yeah.
that? It's very difficult. So, I mean, it's a very difficult scenario, Suresh. I'm not saying. I mean, I don't think there was nothing that she could do, but
Sure.
I don't know. I just felt that, like, it was and I am so grateful that it sounds awful that he had the acute urinary retention, because that got him into hospital. If he didn't have that, I don't know how we would have managed the situation.
Yeah. Well, of course, that's then, becomes a medical, non-psychiatric. And so it's like, oh, okay, well, we can treat that. Yeah, get him
Yes,
in, and, and
yes,
so
yeah,
on. And then, well, now he's here, we'll treat everything, we'll treat the other stuff as
yes.
well.
But even
Yeah.
then, trying to get him to stop them discharging him once they sorted out the urinary problem was like, no, no, he can't.
Oh,
That
really?
wasn't. Yeah, no, no, it was. And so what the system there is that if somebody is admitted under a medical grounds or surgical grounds, um, even if they have a mental health issue, they are not under the care of a psychiatrist. So the psychiatrist comes and sees them, but they're just as visiting, so he's not actually under a psychiatrist, under the care of one. So this was like, I mean, he didn't actually leave, he never got to leave the hospital. But my concern was, well, but who is he under? Because eventually when he
Mm.
comes home, he needs to have some review, or I mean, that's what would happen in Australia and in England. Even for a short period of time, you would be under that specialist until they're happy and that he's stable or whatever, and then discharged to the GP or whatever. But there was, that was, yeah. So, but anyway, he
Yeah.
got the treatment he needed, but it was these were concerns. Um, it was
And you
quite
just,
difficult.
yeah, and you kind of just got the impression that the whole patient approach was just not
No,
there. It was
no,
like,
it
well,
was.
we're treating
I
that
was,
disease,
yes,
not
exactly.
the
So we're
patient.
urology, we're emergency, we're oncology. That's how it was. Um, and yeah.
Yeah. And did you get a sense? I appreciate maybe it's difficult for you to know, but did you get a sense that that was the doctors or that was the system
No, I
that
think
was
it was
like
the
that?
system. Every single individual, from the paramedic to the receptionist to the nurse to the doctors, truly they were amazing. Individually, they couldn't have cared enough. I mean, they were just brilliant. But I think they were these constraints that they had to work under. This was the way it was. This is the way it is over there. And then speaking to just speaking to family friends over there, during his funeral, that is what came out, that it is very much, it is very difficult if you have complex problems, that kind of going from eh, that cohesiveness is kind of not as good, I think.
Yeah. Um, we also touched on, or you also touched on ketogenic diet, and that kind of just got dropped in, and then we kind of moved on. So,
Yeah,
and that's
that's
also
right.
what you wanted to talk about this evening as well. Um, Maybe perhaps Nilam, you can just explain why you mentioned the ketogenic diet. I know people out there are going to probably already know listening to this, and probably the title of the video and whatever else, they're going to get it.
Yeah,
But
yeah,
maybe just, yeah, people listening in the car, you can explain
yeah.
why you mentioned the ketogenic
Why?
diet.
Okay, because the current theory for cancer management, or for the origin of cancer, is called the somatic mutation theory, which says that most cancers are due to genetic mutations in the DNA. And these are, so that's what a lot of that's the current theory that people operate under. But actually, there's not a new, it's been around for the last 100 years, but a theory called the mitochondrial metabolic theory of cancer, which is now gaining a lot more, what shall we say, substance, because there's a lot of research being done. And what that says is that, in actual fact, the it is damage to the mitochondria. Mitochondria are the powerhouses within our cells that produce energy, and chronic damage to the mitochondria causes them to not be able to produce sufficient energy, and that then leads to, so I'm sorry, it's a little bit of a convoluted, but I'll get to it.
Right.
That leads to the cell adapting a very primitive form of respiration, oh sorry, primitive form of energy production, which is called fermentation. So yes, and so these cells, these cancer cells, so damage happens over time to the mitochondria from a variety of things. So it could be toxins, any kind of carcinogen, environmental toxins, radiation, certain medications, smoking, obesity, inflammation, high glucose, certain viruses, any of these things. And it happens, the damage is a gradual damage, because if there's acute quick onset damage, the cell dies, the cell can't manage. But damage that happens over time gives the cell the ability to adapt and adapt to survive, because now what happens in the mitochondria is that it produces a good functioning mitochondria produces a lot of energy, and energy is our currency for survival. And because of the damage to the mitochondria, if it is not able to produce enough ATP, which is our energy currency exactly, to survive, then the cell knows that it's going to die. So in an attempt to survive, it actually adapts this fermentation process. So fermentation is a process that generates energy without oxygen. And the substrate that is used is glucose and glutamine, which is a type of amino acid. And so, and glucose and glutamine, so what the cells use these, they are not very efficient at producing energy. They only produce small amounts of energy compared to mitochondrial respiration. So therefore the cell has to adapt to take huge amounts of this glucose in particular to be able to survive. So the idea then is that if you somehow manage to, and these cells, these cancer cells are very primitive. They don't have the adaptability that normal cells have. So if you then stop them getting the substrate, so either particularly the glucose, then they start to get weaker and weaker. And so that is the idea. So the glucose, easiest way to stop this cancer cell getting glucose is either fasting, water only fasting, but that's not sustainable long term. You can't fast forever. And a ketogenic diet, a proper ketogenic diet, not low carb. You have to be in ketosis. So basically, if you're in ketosis, cancer cells are not able to ferment or use non-fermentable substrates. So they cannot use fatty acids or ketones as energy. So therefore, by being in ketosis, what happens is that you are depriving the cancer cells of their substrate, while we know the benefits of ketones to the other cells in the body while strengthening the rest of the body, rest of the cells. So that is how a ketogenic diet works, and fasting works in this mitochondrial metabolic theory of cancer. And it's not only that, you have to then address things like anything that increases glucose. So stress management, sleep management, making sure that all of those are really kind of prioritized, making sure that people exercise, particularly muscle building, resistance training, because that increases the survivability in particularly in these stage 4 cancer patients who become very hectic, or the loss of muscle because of the cancer. So all these things, these are all lifestyle factors that unfortunately these are not given as an option. And in fact, so my brother, because we had talked to him about it, he knew about these things. And I went to him on one of the visits to the hospital. And this is the visit that he was given the medication to start. And my brother asked the nurse about a ketogenic diet, and she actually didn't know what it was. And I
Really?
felt
Wow.
that she didn't know, and I felt, how can you, how is that possible if you have this theory that's coming out, that surely it's yeah. So that was interesting, but that wasn't offered. That's and so I that is where I feel that a lot of improvement could be made. I'm not saying, I think for a lot of people, the conventional therapies are important, but if they are offered in conjunction with, a ketogenic diet, why is it important? Stress management. I mean, not just lip service, proper kind of, stress management, sleep, exercise, all these things that need to be in place. I think it would make life so much better for these patients who have these kind of advanced, or any patient with cancer, any patient with any illness, really. We know that it helps.
Yeah.
But I think modern medicine, that's the tragedy, I think, that we just pay lip service to these, and most doctors have no idea about the
Yeah.
importance of these therapies.
I think you're right. I mean, I think you did a very, very good explanation. I mean, people watching on YouTube can probably see I've been trying to share the screen. I mean, the kind of mitochondrial kind of energy production is just like, it's just a mess. Like, it's so complicated, and I don't expect anyone to kind of look at this and go, "Oh yeah, I can understand all of that." I don't
Yeah,
understand.
yeah, yeah.
I don't know about you, Dr. Nilan, but this is kind of over my head. I think I kind of tapped out in medical school with the Krebs cycle, the TCA cycle. This is one step
Yeah,
kind of
yeah.
on that. But yeah, I mean, essentially, for people, I'll put the link in the episode description. But it's this paper by Thomas Seyfried
Thomas Seyfried. Yeah.
and Christos Ginopoulos. I apologize if I've said that name wrong. Can the
Yes.
mitochondrial metabolic theory explain better the origin and management of cancer than can this somatic mutation theory? So I think, as you kind of correctly put there, I mean, it really kind of boils down to what actually really potentially causes cancer. Is it really a genetic condition like I'm sure you were taught in medical school, I was taught in medical school? It's a genetic condition. There's not really anything you can do about it. And we have to treat the genetics of it. And all these chemotherapy drugs and so on, they're all kind of predicated on, well, it's a genetic disease.
Yes.
But I think the work here of Dr. Seyfried is actually kind of based on, as you said, I mean, 100 or so year old work by Otto Warburg, sorry, and this kind of, I think what he was demonstrating, this Warburg effect, if I recall correctly, and I apologize if I'm not, was essentially that when you take damaged mitochondria or cancerous mitochondria, put them into healthy cells, they act like cancer. When you
Yes.
put normal mitochondria, so non-cancerous mitochondria, from cancerous or into cancerous cells, they don't act like cancer. So it's in effect, is it the mitochondria that's actually controlling the cancer, as opposed to it's actually the cell in entirety? And then, of course, that kind of led then to, well, what's driving the mitochondria? Well, it's essentially, energy production. And what they
Yes.
found was certainly some, if not many, if not most, if not all, cancers then might follow this kind of fermentation route, which is different to the normal, kind of metabolic oxidative
Yeah.
pathway.
Phosphorylation. Yeah,
Yeah,
that's right. Yeah.
oxidative phosphorylation. That's taking me back to medical school days, and which essentially is the normal kind of route. So oxidative phosphorylation, yes, you can use glucose as a substrate. You can use glutamine, pyruvate, ketone bodies, and fatty acids, and all those kind of good stuff. But with the fermentation route, essentially, my understanding is the further the cancer kind of goes down that route, the worse the cancer gets, the more undifferentiated and so on.
Yes.
The more it kind of goes down that fermentative pathway and effectively lacks the ability to then use ketone bodies as a fuel source.
Yeah.
Therefore, if you can starve the cancer cells of the glucose, which realistically we can't do 100% because the body is producing some glucose, but I mean, pretty close to, we can get rid of a lot of the glucose. Then theoretically, I mean, it's almost the perfect chemotherapy. I mean, theoretically, with little to no side effects at all, if not also, of course, positive. But yes, it raises the question: well, what really actually then drives all this damage to the mitochondria in the first place? And that's, yes, when you go back to chemicals, radiation, smoking, and all these other kind of, toxic things that we put into our bodies nowadays. I did an episode recently, just last week, on breast cancer and oxalates, and I spoke about oxalates at the keto retreat. Shout out to Emma from Lazy Keto Mum. Hi, Emma. I know you listen to the
That's
show.
right.
She always puts on a good
Wonderful.
conference. And I know obviously you were missing that because you were over in the States with your brother, and you were very
Yes.
dearly missed. But I was talking about oxalates and, and how these also cause issues, damaging DNA and, and so on. This chronic stress, state,
Yes,
basically,
absolutely.
which can
Yeah.
then cause this. We know, of course, chronic stress raises inflammation. And
Yes.
acute stress, acute inflammation, it's generally useful within the body, but chronic stress, chronic inflammation, yes, generally bad, generally damaging.
Mm.
And then of course it's going to lead then to this mitochondrial damage and, and so on. But theoretically, yes, ketogenic diets, and as you said, not just low carb. I mean, low carb is probably better than the standard diet,
Yes, but
but
yes,
specifically ketogenic diets
yes,
in nutritional ketosis. Again, we're not
that
talking
is it.
30,
Yes,
40, 50 grams of sugar. We're talking, are you in nutritional
yes.
ketosis?
So that's more than 70, 80% fat in the diet.
Typically, and
Which
it's
is,
gonna be typically 20, 30
yeah,
grams maybe of carbohydrates, just as a
yeah,
rough number, but again, everyone's going to be slightly different there.
yeah,
That's potentially then that kind of sweet spot then for starving the kind of the cells potentially as much as possible. But of course
yeah.
we know that ketogenic diets have been proven to reduce stress,
Yes,
lower stress, and lower inflammation, improve brain functioning, and so on, improve
so many benefits.
recovery,
Yes,
and
yeah.
a lot of benefits there. So and so that's really the theory there is, if we can starve the body, starve the cancer cells of their substrate, their energy source, well, can we then potentially starve out the cancer? It's tricky because they also can use glutamine.
Yes, and so glutamine you cannot, there's no dietary way that you can control glutamine, because glutamine is one of the most abundant amino
Yeah.
acids in the body, and it is absolutely essential. Well, it's not an essential amino acid because we produce it in our bodies. So there are now repurposed drugs that are being trialed to try and manage the glutamine. But I mean, there's so much potential in these therapies. And Suresh, there's a docu series called Cancer Evolution, that all these kind of scientists and MDs who in the States, they produce this, and they talk to also a lot of cancer survivors. So survivors, as in, because you can't call them healed, but survivors who have survived for many years longer than you would expect. So I mean, and the stories are fascinating. And there's one in particular, Pablo Kelly, he's from Ireland, and he had the glioblastoma multiforme, which is the worst possible, the most one of the brain cancers. And he's survived 8 years now, um, refusing all conventional therapy and just going down the metabolic pathway. I'm not saying that that necessarily has to happen for everybody, but there are so many stories now, N of ones coming up and survival stories coming up, that I don't think that we can just say, well, oh well, this is who, whatever, because at the end of the day, when you're talking about stage 4 cancers that have a very low survival rate, anybody who survives, we need to look at, well, what did they do?
Yeah, you're absolutely right. And I mean, again, like, make it clear. I know you've already said it, but we're not telling anyone to stop,
No, no.
traditional therapies, conventional therapies, chemotherapy, anything like that. No, but a ketogenic diet can be done with all of that,
Yeah,
just in the background. I mean, I'm sure you've got some patients with cancer, unfortunately, as well, and they often tell me doing a ketogenic diet helped them, at least with their chemotherapy. They
yeah,
felt they just recovered quicker, more energy, less stressed. Their body just
that's
kind of
it.
seems to just do better when they were following that that ketogenic diet. I also want to very, very quickly, if I can share this screen, hopefully that works. There we go.
Oh, yes.
Again, I apologize. Anyone that's listening on the podcast, you can't see this. Again, I'll put links there. But this is the Paleo Medicina website. And I found, again, I'm apologize if I'm wrong. I think these guys are in Hungary, if I am correct. There we go. Yeah, Hungary. I got it right.
Okay.
And Dr. Zofia Clemens, a lot of people will know her and the work of her team. And they're doing amazing work with what they're calling this Paleolithic ketogenic diet, which is essentially, a modified ketogenic diet, somewhere in between, kind of maybe a slightly more relaxed carnivore. So it's a very specific diet that they've kind of come up with. But yeah, seemingly they're getting amazing results. I think, is it John Hopkins in the States, I think, is now trialing or has been trialing ketogenic diets as a add-on, add-on therapy for cancer as well. So I think your word kind of is getting out there a little bit that maybe there's other ways of approaching these things, and I think there is hope.
And for people as well, I think it just gives them a sense of control if they are given these lifestyle therapies, because they actually can do something about their own illness. They can, rather than just have the medication or go in for radiation or whatever, they also can. There's so much that they can do to improve their likelihood of survival. So I think it's really important to empower people, I think, to give them that option.
Yeah.
Yeah.
And that's incredibly powerful when people can actually feel empowered to do something for themselves. And this is why I think people seek out alternative therapies and, do all
Exactly.
sorts of things, which again, we're not necessarily recommending now, but yeah, because they want to feel like they can just be part of their own journey and not just
Exactly.
have things,
Yes.
kind of done to them. So I think, ketogenic diet potentially has a huge role here. This mitochondrial metabolic theory, I think, is definitely very interesting. I get a number of patients, I don't know if you do as well, seeking me out, wanting to just do this, just because they're either they've tried everything, they've been
Yeah.
told nothing, no more treatment, or they just want to do it alongside it. And it's kind of sad that they're maybe their usual doctors just telling them, no, it's going to harm you, it's not good for you, when there's absolutely no evidence that that's the case whatsoever.
No. No.
Even if it doesn't improve things, okay, that's one thing, but there's no evidence of harm
No.
really from at least short-term ketogenic diets. It's very, very well studied. And if there is any potential, long-term, maybe a very slight stress effect in the long term, it probably pales in comparison to the potential, potential
Benefits.
benefits here.
Yeah.
So,
Exactly.
yeah, so I think there's not really any evidence of harm. I don't see why more people shouldn't be necessarily at least looking into it,
Yeah.
and then of course making their own decisions there.
Yeah. Exactly. Yes.
Yeah. So,
So
yeah. Look, I mean, was there anything else that you wanted to discuss at all this evening,
no,
Doctor?
I think that was really, I think, just to say that I think we need to, you know when people get these very kind of serious and scary diagnosis, they're scared, and they are just wanting whatever, something to help them. But I think it's such a pity that we don't offer, in conjunction, hand in hand, or as important to first, let's do these lifestyle therapies, and let's do this as well. And I think would be the ideal way to treat people and give them a sense of control, give them the ability to make their own decisions on what they need to do. And also, that I think also reduces the dosages and the frequency of these strong, toxic medications, because they are toxic. I mean, your
Mm.
hair falls out with radiation. You can have, sometimes a little bit of neurological side effects as well. So these are not things that, and as with my brother, I mean, it obviously, that's what he died of at the end of the day, months or possibly years before he would have died from his cancer. So I think, these are not without risks. And I think it's really good to have an alternative, not an alternative, but adjunctive treatments that can be used in conjunction with conventional therapies. And I think we need to all be thinking about, not just for cancer, but any illness that we treat, that we're not just, I really feel that sometimes a lot of us pay lip service to these lifestyle therapies, and we really need to know for ourselves what to tell patients so that they can benefit from these.
Yeah, no, I absolutely 100% agree. Um, I realized, I think, just at the start of the podcast, I didn't really introduce you terribly well, because you're a returning guest on the show, and people may not actually know if they haven't listened to those previous episodes. Maybe you can, just before you leave, tell us a little bit about Whole Food Revolution and what's happening with that at the moment.
Oh, okay. So I'm a GP. I work in the north of Brisbane, and I'm the founder of Whole Food Revolution, which is basically a platform that educates people on metabolic health, on not just the diet, but the complete lifestyle. So I work with two other women. I work with a nurse and a life coach. So I feel that we have a holistic approach to this. So I teach the science. Deb talks about the practical implementation of that. Thank you, Suresh. And Ronit is the life coach, and she's all about the mind. So so that's what we do, and we run. We run various workshops, and so that's what we do. So it's all about education, and we really enjoy that, and we have a good time doing it.
Yeah, I mean, I've heard you talk, I've heard Deb talk, I've heard Renit talk, and you guys are all fantastic. And you really know your stuff in your respective areas, and very, very highly respected. So anyone, north side of Brisbane, definitely go check out Dr. Nelum and Whole Food Revolution.
Thank
Well,
you,
thank
sir.
you. You're very welcome. Thank you again, Dr. Nelum, for coming on the show and sharing your truly heartfelt, heartbreaking story with myself, with the listeners, with the viewers. I think there's going to be people out there that will be able to identify, I think, with what you've said, sadly. And hopefully, I just think, maybe I think in your hope was maybe there's just some doctors, that clinicians that just listen to this and maybe just think, okay, let's read this paper. Let's just talk about it. And even if, they don't know what they're doing with low carb or ketogenic diets, just say, look, this might be an option. Go
Yeah,
see your doctor, go see this person, go see Dr. Nelum, go see myself. And just talk to someone who maybe does,
yeah,
that they can just talk you through it.
that's right. Yeah, yeah,
Yeah,
yeah, absolutely. I think that. I mean, that's a really good start. If we can get people to do that, then I think that at least the mind has been opened a little bit.
absolutely. And I think that's really just the goal here, is just get people thinking about it, talking about it, and just realizing maybe that there's maybe a different way, or an additional way.
Yeah, additional way. Yeah, I think that's it. Yeah, yeah, that's right.
Well, thank you very much, Dr. Neelam, again, for coming on the show. Really do appreciate it. And thank you guys for tuning in to this episode of the Meat Medic podcast. We'll see you guys in the next episode.